Good evening, everyone, and welcome to the webinar on sequential use of TKIs in management of lung cancer. I would like to invite Dr. Koushik Chatterjee, Assistant Professor, Department of Oncology, IPG-MER and SSKM Hospital, Kolkata. So over to you.
Yeah, good evening, all of you. So I think at the outset, I would like to thank Kavina Creations and Boringer to be helping us out with this interesting event, and this event will be mainly focusing on the sequencing of Egfr TKIs in lung cancer. And when we say lung cancer, we are purely talking about Egfr mutated, the stage 3B and 4 lung cancers. And why I say sequencing will be a very interesting thing to discuss, it's purely because we have so many options right in front of us. There is so many varying data, and there are so many variables that are going to help us choose between each treatment as compared to the other. Therefore, it can be a over time running debate over and over again. And also in this context, I would like to say we are right now going through the second wave of COVID-19. And having said that, we are continuously suffering from this fear of death for such a long time. And in this situation, being able to tackle such a devastating disease as a stage 4 lung cancer would be also a very interesting thing to know. So I would now like to call upon an eminent oncologist of this country as well as in the state, my dear friend, Dr. Amitabh, who's currently a senior consultant attached with HCG hospitals in Kolkata, Narayana Super Specialty, and Ruby General Hospital, Ruby Cancer Center. He's also attached with KPC Medical College and so many other centers. So, and believe it, listening to him would be a pleasure for all of us. So we do welcome Dr. Amitabh to speak upon how do we go about managing lung cancers in the setting of COVID-19. Amitabh, over to you. You can share your slides and carry on, please.
Thank you, Koushik, for your wonderful introduction, and always great to be on the same platform with you, even if not physically, then at least virtually. We can share our thoughts and try to maybe make a difference as far as the treatment of a particular subtype of cancer is concerned. And is my screen visible?
Yes, sir.
Yeah. So I have been tasked with talking about lung cancer management in COVID times. Now, we all know that COVID has only been around for the last 2.5 years, at least in the current form that we see it. It's been around for much, much longer. In fact, we have been answering questions about coronavirus in our MBBS exams for time immemorial, but nobody would have thought at that point that we'd be facing a situation where losing loved ones and friends and so many others to this dreaded disease. So we don't know much about it. So if you look at lung cancer as a disease, there is a lot more for us to learn even in that area. So we're basically talking about two things that we still are finding out things about. So most of what we will be talking about today would be based on the best evidence that we have till date. So before we move on to Koushik's presentation, which is the core of today's seminar, today's ECME, I'll be talking about the peculiar situations that we oncologists have been facing in the treatment of lung cancer, and trying to use some recommendations from international organizations. Please understand these recommendations would not be as evidence-based as the next presentation that you would be seeing subsequently. And if you do have any questions, I would possibly not be, completely comfortable answering them with all honesty, because as just told you, this is an evolving situation. We still need to know a lot more about it. So this is not news for any one of us. Lung cancer is a significant global health issue. Now, the problem with lung cancer is, although it is not the commonest cancer that we see, it is the most lethal cancer that we deal with 2.1 million new cases being diagnosed all over the world and 1.8 million deaths being reported all over the world. Now, translates to an unacceptably high mortality for one particular type of cancer. And this is something that all of us have been trying to work towards trying to reduce these numbers, also to reduce the incidence. And that will be reflected in the last slide of today's presentation as to what we're trying to do to actually try to bring down the incidence of this cancer. World over, lung cancer is a problem, but in India, it is still not the kind of problem that probably the Westerners see it as. It accounts for 7% of all new cancer cases. But these numbers have been, sort of going up with time, and these are worrying trends for us. Now, if you look at the, the reason for this happening is that probably we are a country which is still learning to smoke. We were smokeless tobacco users for a very long time, and that has, with westernization, being converted into smoking tobacco. And our cancers are shifting from the oral cavity and the oropharynx and the larynx down to the lung. So you're taking maybe a worse cancer and making it commoner in India as compared to head and neck cancers. But having said that, we would probably not want any of these cancers to be things that we would be facing, all tobacco-related cancers, that is. But despite that, this is the harsh reality. We are seeing larger number of lung cancer patients in our practice that we were seeing maybe a decade back. 85% of these are non-small cell variety, and that is something that kind of tells us that there is an opportunity for us to work with modern oncology to give better outcomes, because in the small cell subvariety of lung cancer, which constitutes 15% of the cancers that we see in our practice, not much has changed with time. But in the non-small cell subgroup, as Dr. Chatterjee would be showing you eventually, things have actually been turned on its head, and we are now seeing very different outcomes to what we used to see earlier. Staging of cancers is a question that Koushik and I love to ask our students, because it's something that has changed with time and something that can help you pass an exam. What's important for us to understand is that close to 50% of our patients would come with stage 4 lung cancer. This number has not changed very much over the years. With the introduction of low-dose CT screening for lung cancer in the West, these numbers seem to be now changing into more and more stage 1 and stage 2 cancers being diagnosed in high-risk asymptomatic individuals. But overall, the incidence of stage 4 lung cancer still remains something that we would like to change with time. So within this group is another stage, which constitutes about 20% of the patients that we see, and that is stage 3B. This is also a very difficult to treat group of cancers as far as stage is concerned. And in a majority of the studies that will eventually be presented to you in today's sequencing studies or sequencing trials, these would have a combination of stage 3B and stage 4 being presented. So that's how difficult it is to treat a stage 3B. So a large majority of our lung cancers, from the point of view of stage or the amount of disease that you are presented with in your patient, are advanced, so-called difficult to treat, or chronic cancers, as we like to call them today. And why is that important from the perspective of an oncologist? Because as expected, a stage 4 lung cancer would have an extremely poor outcome, with only 2 out of 100 patients surviving 5 years. And even these patients would be those who would have a molecular subtype which would help them to survive that time frame with the help of non-chemotherapy, non-radiotherapy treatments, which would be chronic treatments which would help them survive that long. And 3B is not very different, as you can see here. And the others are also not numbers that we are happy with a stage 1A having a survival of only 50%, 5-year survival. So these are numbers which are being, constantly looked at for improvement. And I'm happy to share that these numbers seem to be improving with time. Maybe not in the Indian context so much, but at least as far as our Western colleagues are concerned, their numbers seem to be definitely better as far as the survival figures go. So what are our treatment options? This very simplistically would be 3. Surgery being still date the most efficacious treatment in early stage lung cancer, and my radiation oncology colleagues in the audience would now be, saying all sorts of things to me, because early stage lung cancers, radiation oncology can do as good a job as our surgical colleagues. Apart from this, we have medical oncology, which has actually made a huge difference as far as advanced lung cancer is concerned, with targeted therapies being the first major change from chemotherapy that we had. And then eventually now even immunotherapy becoming a very important tool in our armamentarium. So the changes have happened only very recently. So if you go back in time, you only had chemotherapy in the 40s for advanced lung cancers, which didn't change too much with time. You had options in chemotherapy come in with time, but again, things did not improve very much till the early 2000s when you had targeted therapies being introduced. And now there's a deluge of targeted therapies and immunotherapies, at least between 2010 and 2020, which has really changed the way we treat our lung cancer patients and given them a lot of options outside of the standard therapies that were used in the past. Coming to something I don't know too much about, being an oncologist, if there are microbiologists in the audience, they would be better placed to explain these to us. But since we don't have that luxury, I'll try to do what I can. So the coronavirus are positive sense single-strand enveloped RNA viruses belonging to the family Coronaviridae. It is derived from the Latin corona, meaning crown. Novel coronavirus 2019, known as SARS-CoV-2, is what we are now dealing with as the pandemic, and it appears to have been zoonotic infection that has adapted to animals, something everybody had been warning us about for a very long time. And this was the reason why we were killing off so many chickens when we were looking at bird flu and so on and so forth. But eventually that jump was made, and today we have this pandemic with us for the last almost 2 years now. So in cancer patients, how does the COVID infection change the outcome? We obviously, as expected, have the first data coming in from China. In fact, from Wuhan, where the initial experience with patients with cancer with COVID disease was reported, and the reports were actually all negative. Now, these reports essentially tell you that cancer patients who have a COVID infections do worse as compared to patients who do not have COVID infection. So this was probably one of the reasons why cancer patients were placed on a high priority list when COVID vaccination was introduced as a governmental policy. So the need for ventilation, the outcomes as far as very severe events is concerned is very high in patients who are active cancer sufferers as compared to patients who have recovered or who have never had cancer or recovered from cancer. So ASCO recommendations, the American Society recommends anti-cancer treatment to be continued as per plan in cancer patients, but the treatment needs to be individualized, with oral therapies being preferred over injectable therapies, and changing the frequency of delivery of the treatment that you are planning for your patients. So this is a general recommendation across the board for all cancers. How this translates to lung cancer in particular is what you see here. So if a patient with lung cancer is asymptomatic, they are given a screening questionnaire, something that we have introduced in one of our hospitals for treatment of breast cancer. So if on the screening questionnaire, which includes, downloadable sets of questions now, which deal with exposure to patients with COVID, to the incidence of COVID in the locality they are from, or to, having symptoms of flu or upper respiratory symptoms, to so many other questions which give you an idea whether this is a patient who needs to be tested for COVID. And if they do need to be tested and they come out positive, we delay the treatment or hold systemic therapies and consider holding oral TKIs in these groups of patients as far as the concordance of COVID infection and cancer goes. But if they are negative for the questionnaire or negative for the test, they continue treatment or initiate treatment as planned for them. So when we are planning these outpatient visits for these patients, we give high priorities in patients with advanced stage disease or patients who are, obviously symptomatic with the common symptoms of lung cancer. We are trying to convert these patients to telemedicine visits as much as possible, primarily because we don't want them to be exposed to, COVID infection, asymptomatic carriers of the infection, especially healthcare providers who seem to be a very big risk group in this group of patients. So the next question is, when do we ask for investigations? The standard investigation would be with any respiratory symptoms, not just for cancer, but also to exclude the radiological features of COVID. It would be used for a staging workup, definitely, when you have diagnosed cancers. If you have a stage 3 or more lung cancer, you would definitely want them to be biopsied, for which you would need a high priority for CT scan. And if you are observing symptomatic deterioration or any kind of clinical evidence of disease progression, you would ask for a CT scan. Again, this would need to be converted to as many telemedicine visits as possible. Now, one obvious question which comes out is, then don't we biopsy earlier stage lung cancers? Now, there would be a lot of debates coming out of this, because there are countries where you would be treating patients with early lung cancers with stereotactic ablative radiation, even without taking a biopsy. Whether that could be done in the context of COVID or in the context of the endemicity of tuberculosis or any granulomatous disease like it is in India is again open to debate. And please remember, these are guidelines coming out of the West, and therefore might not be directly translatable to the Indian context. So in our context, taking biopsies would still be a high priority even for early stage cancers. So what about the surgical approach? And this is not something I'd be able to help our audience with much, but then the obvious surgical interventions would be for symptomatic patients with effusions, empyema, or pneumothorax. If you have an early stage lung cancer and you have them to be, COVID negative, and you are confident about getting it out, then this would not dissuade you from undertaking surgery in this group of patients, and would be high priority. A thoracoscopic biopsy and pleural biopsies for situations where we do not have a diagnosis of malignancy yet is something, again, which becomes high priority in this group of patients. When to give chemotherapy with high priorities? It is in the first line to improve prognosis, cancer-related symptoms, and quality of life, definitely from small cell lung cancer and inoperable stage 3 NSCLC, and in the combination with radiotherapy with curative intent treatment being delivered for lung cancers in this group of patients. Now, coming to driver mutations in NSCLCs, what does the term driver mutation mean? Essentially, give me a second, please. So driver mutations in NSCLC would be mutations which are known to be proto-oncogenic and which lead to the progression of cancer when present. And these are usually transmembrane, or intracellular second messenger pathway components, which are known to drive the growth and the differentiation of normal cells. And when they are constitutively active, they do the same to these to these cancer cells and subsequently lead to their progression. There's an entire family of these. I think Dr. Chatterjee will be, talking about them in much greater detail. Just to share with you that the most commonly targeted area for this mutation subgroup, or the driver mutation subgroup, is the epidermal growth factor receptor subgroup, which is again a heterogeneous group of various kinds of mutations that can happen. And Koushik and I even had a publication from Eastern India regarding the commonality of the mutations and the comparison of the types of mutations observed in India versus the rest of the world. So this, I think, will also be part of the presentation with Dr. Chatterjee coming forward. So this very, very busy slide and extremely, difficult to probably go into every little detail, but this just is a slide which gives us hope. Hope that each mutation that we know as an oncogenic driver today does seem to have some kind of molecule to inhibit it. And this is in the background when we ask for the tests, which are now probably the most hotly debated tests in oncology, which is the next generation sequencing tests. These give you a list of mutations that are present within the cancer. And you could even land up with mutations which were unknown in that subsite, anatomical subsite, but you have a molecule for that kind of a mutation. So this would now translate to molecular oncology rather than anatomical oncology, like what we've been practicing all this while. And this entire chart, you would see one gray area, and this has been gray for a reason, and that is the KRAS mutation subtype. But happy to let you know, I'm sure Koushik will also talk about this in slight detail, you're now getting, molecules to deal with the KRAS mutations as well. So what about targeted therapy during COVID times? So targeted therapies probably are the safest of the lot when you look at COVID and cancer. So since chemotherapy can kill both healthy and cancer cells, and targeted therapies do not, very obviously tend to do so, although they do tend to kill off certain cells which bear the same target as the cancer cells themselves. But the therapeutic ratio with targeted therapy, at least the EGFR targeted therapies, seems to be pretty impressive. You also have ALK inhibitors, which are another subgroup of the mutation-driven cancers, and MET inhibitors now, which are available for commercial use in patients with driver mutation-positive lung cancers. So targeted therapies should be continued as expected because these are probably the safest of the lot in the context of COVID. It can be initiated in newly diagnosed cases and given in second line on disease progression. But what one needs to be aware of is the differentiation of a tumor flare versus a COVID-related radiological abnormality, because it's a well-known fact that EGFR mutation positive, and we'll limit our discussion to EGFR because that's probably the best known and the longest experience, of therapy mutation that we have in lung cancer today. So the progression when we stop these oral tyrosine kinase inhibitor EGFR TKIs is extremely rapid, almost like developing an infection. Within days to weeks, you would have newer lesions come up. Now, these have to be, kept in mind when you are looking in the context of somebody developing a COVID pneumonia, because the radiological as well as clinical picture might not be very different across these two subgroups. But what would be different is you could resume the TKI, even in the context of suspected positivity of COVID, and get a response with that. So it's something like having a therapeutic trial of TKI in a patient who is suspected to have progression on stopping of TKI versus developing COVID pneumonia with lung cancer. Now, coming to something which is probably a little more difficult and a little more, important in the modern oncology context, and these are the immune checkpoint inhibitors, the most, the new phase of immunotherapy, if you may call it that, in cancer. These inhibit various pathways within the immunotolerance pathway which the cancer cells seem to develop against T cells, and multiple molecules that we now have are approved for use in lung cancers. So immune checkpoint inhibitors and lung cancers are difficult because these immune checkpoint inhibitors seem to also produce pneumonitis independent of cancer as an independent side effect of the therapy itself. So if a patient on immune checkpoint inhibitors comes to us with pneumonitis, how do we make this distinction between the COVID infection versus, ICI-related pneumonitis? So essentially, we look at the other signs of COVID pneumonia or COVID infection that could help us clinically distinguish this. So if you are looking at COVID pneumonia, you would also probably find anosmia with fever. You'll get an IgM positivity as well as PCR positivity. But when you have ICI-related pneumonitis, these would probably be absent or low, depending on the situation. So how do you manage? And this is important because COVID essentially requires steroid at some point in time during their treatment, whereas the use of steroids would probably lead to loss of efficacy of the immunotherapy being used. So this is something that we have to keep in mind when designing the therapy of a patient who is suspected to have pneumonitis or is presenting with clinical pneumonitis, and we have to make this distinction, and this distinction needs to be made quickly. Thankfully, now that steroids are not kind of recommended within the first week of COVID pneumonia, we do have the luxury of time to help us decide as to which kind of pneumonitis the patient seems to be suffering from when they present to us with this particular symptom or this particular situation. Now, coming to our core specialty, which is radiation oncology, and I can probably say this with some level of confidence, having treated maybe a dozen or so patients who had either COVID pneumonia and were eventually diagnosed with a lung cancer as an incidental finding when they underwent a CT scan to look at their degree or look at their CT score, as they are now calling it, for COVID. And on the other hand, we've had patients who've been on treatment for lung cancer and have developed COVID pneumonia and recovered from it, and we've lost some patients to it. So whatever be the case, the answer to the use of radiation in the COVID situation might not be as simple as one size fits all. But what we can definitely say is that it is safe to use, and we have used it in COVID survivors, as well as use it safely in patients who've actually been acute COVID pneumonia patients who've recovered from their pneumonitis and then come back to take treatment. What I have been doing in my practice, and I'm sure others can contribute, is try to use as conformal as techniques as possible to avoid low dose regions to opposite lung as far as radiation is concerned, and request my medical oncology colleagues to delay the use of concomitant by at least a week so that we can understand whether a patient has the lung reserve post-COVID pneumonitis to tolerate a course of radiation. Now, whether the lung function at baseline, makes too much of a difference as far as the tolerability of radiation is concerned, I honestly do not have much of an experience with this, at least as far as COVID pneumonia recovered patients are concerned. But we know it from our data regarding pneumonectomy versus the use of radiation in high volume lung cancers, that there are guidelines available which help us make that decision for healthy lungs or patients with non-COVID lungs, if I may put it that way. So it is definitely high priority in inoperable stage 2 and 3 or limited stage NSCLC or in the metastatic setting. It's safe to use. We've used it in COVID positive patients in the palliative setting as well. We've used it in COVID recovered patients, and they are successfully completing treatment. So the personal interpretation, although this is not my personal interpretation, but it makes sense for all of us, it is to keep on diagnosing and treating lung cancer. Discontinuation is clearly not recommended as far as available data is concerned. They should follow recommendations to avoid COVID-19 infection, as should be all. And every patient who has COVID-19 infection should have infection excluded before admission to an oncology center. Again, something that all of us are doing regularly. There is no recommendation regarding preventive use of antiviral drugs. In fact, even the curative use of antiviral drug is now being questioned across the world. And finally, we do tend to avoid adjuvant treatment, that is treatment in a post-resected lung, say, for example, who does not have any, high risk factors for recurrence, obviously, who would require chemotherapy as far as the current guidelines are concerned. But we would not subject them to chemotherapy if they had any of the other high risk factors for development of COVID related problems. So thank you very much for your patient hearing. And this is what I was trying to tell you, how we are trying to reduce the incidence and not just improve the cure rates of lung cancer. Thank you very much.
So I suppose that was a wonderful and extensive presentation on how do you go about dealing with lung cancers in the situation of COVID-19, the second wave specifically. So with that, the ball was already set rolling, and now I would like to call upon Dr. Niranjan Prabhu from Boehringer Ingelheim to have a few words, and then probably I can take up.
Sure, sir. Thank you so much, sir. I take great privilege actually to share flows with both Dr. Koushik sir and Dr. Amitabh sir. So actually, coincidentally, I came across this publication last week, which was actually authored by both our speakers, Dr. Koushik Chatterjee and Dr. Amitabh sir. So actually, this was the first publication that has come from the eastern part of the country. So western part of the world, we have a lot of data about the lung cancer, the mutations associated with it, and we know what are the general, the most common ones, the rare part of the rare ones, etc. But in India, the most of the data either are generated from north or from the down south or the western population. Rarely, EGFR have been studied extensively on the eastern side. So I take the great privilege to introduce this publication to all our participants. So this was the first paper which actually studied the incidence and prevalence of EGFR mutations which are seen in non-small cell lung cancer. So in this study, basically around 106 samples were actually studied. So totally around 108 were there. So 2 were out of scope for genetic study. So out of 106 patients, they found around 35 patients to have EGFR mutation positive. So this is to our surprise that it is exactly as seen in the Western population. And in fact, slightly more we can say, because in Western population, the EGFR incidence is around 20%. Whereas here in this study, in the Eastern population, we found around 30%, 33% to be exact. And the common tests that were employed at that time was mostly it was ARMS PCR, because the study, the patients that were recruited were right from 2016. So most of the time it was ARMS PCR, like 2014 to 2016. So most of the tests done were ARMS PCR at that time, with few patients undergoing even gene sequence, NGS. And in this patient, again, in this patient population, so we all know that lung cancer is commonly associated with smoking. But here in this study, around where I mentioned around 35% of patients actually had EGFR mutation positive, out of which 85%, that is, out of every 7 patients, almost 6 patients were non-smokers. So only 1 out of every 7 patients was a smoker. So here, most of the time, a non-smoker with a lung cancer would have an EGFR mutation positive from the eastern part of the country. And around 50 to 60% of the patients were female. So that is expected. So most of the female patients generally develop EGFR mutation. So, and the same way how we witnessed from various other studies, around the most common mutation that was reported were exon 19, around 51 to 52%, followed by 43% of patients reported L858R, which commonly occurs on exon 21, a part of the EGFR gene. And apart from that, 2 patients reported an uncommon mutation. So one patient with S768I on exon 20, along with a common mutation, which we call it as compound mutation. So a compound mutation with a common, with a common mutation and uncommon mutation. And another patient also had a de novo T790M. This is very, very rare. So they were also able to, out of those 35 patients, they were also able to pick up one de novo T790M mutation. So, again, this is a great privilege, and thanks a lot for this opportunity, because this is the first study that is coming from the eastern part of the country, and this matches very well with other parts of the country as well. The data matches very well with other parts of the country as well. So, very insightful article. I insist everyone to please go through it for a very insightful discussion. Thank you so much.
I think that was a public. Patient to have that publication. I would like to thank Dr. Kumar Prabhash, who expedited this publication within a few months, and that was it. So I think now it's time for us. I'll share my screen to get down to the exact job of tonight. We had excellent discussions all over the place, and so back to exactly what we are here gathered today. Now, selecting the right TKI to optimize the treatment in EGFR mutated non-small cell lung cancer, specifically that of stage 3 and stage 4. So we would slowly want to understand what are the factors that we seriously want to understand while selecting the right tyrosine kinase inhibitor to optimize treatment in EGFR mutated non-small cell lung cancer. There are so many. Out of them, definitely the one on top, efficacy and safety, is very important factor. Whether or not there is presence of brain mets, because we know CNS-specific activity is now a definite way to choose which tyrosine kinase inhibitor to decide upon. We seriously have to choose the first line, basing our understanding that what we are going to do next, because we all know some point of time a resistance is going to set in. And also, like as Dr. Prabhu had showed in our article itself, out of 35 patients in 106 patient population, we could actually identify one de novo T790M mutation, so in whom we already know that sensitizing is not a sensitizing mutation after all, and our first generation TKIs might not be working. So having this upfront idea about resistances This is not an acquired resistance, of course, which I had in our paper. This is an upfront resistant mutation that was already there. So what would be the acquired resistance mechanism in the subsequent lines will also help us choose the first type. So having said that, this is your entire gamut of your EGFR. We have the wild variety, we have the intrinsic mutant variety, we have ERB heterodimers and the acquired T790M EGFR mutated variety. The acquired ones comes after you use up your first or second generation. So on your left-hand side is the basic classification of the first generation EGFR TKIs, namely erlotinib and gefitinib, the second generation afatinib and dacometinib, and the third generation osimertinib. Now the first generation ones, they are reversible binders binding to the wild type and the mutant variety, and they are basically inactive against T790M mutation. But having said that, I must also correct myself in this slide. They are actually not inactive. They are also active, but the minimum inhibitory concentration, that is the IC50 required for this first generation molecules to be holding on to the T790M is so high that their doses will be required in the range of 1000 milligram of say gefitinib, which they, because of their binding also to the wild type variety, is going to cause havoc in terms of side effects. So you can't use that. The second line ones, afatinib and dacometinib, they actually are pan-ERBB family blockers. They are irreversible covalent binders, and they basically inhibit both the ERBB1, that is EGFR, ERBB2, and the ERBB4. They don't have great activity against the ERBB3. Now, their broader activity to overcome EGFR tyrosine kinase resistant mutations. So you must understand, if you are asked to select out one drug which is meant for the rare mutations, it should be afatinib. Now, next comes the osimertinib, which is third generation ones. It is irreversible covalent binder to the mutant variety of EGFR. Mind it spares the wild type. And it is also highly specific for EGFR T790M mutations. So you can't say that osimertinib doesn't work against the common sensitizing mutations like del19 and L858 beta. I'll show you, they also do, but they are highly specific for being sparers of the wild type of EGFR. Next, so how do we go about selecting? Let's understand the hypothesis behind it. Now, if you see, after you have used the first or second generation drugs, the clones that comes upon are very heterogeneous, whereas that is after the first generation. Whereas the broader activity or profile of the second generation TKIs, basically this delays the onset of developing clonal expansion, resulting in a more homogeneous type of a subclone, and this delays the development of acquired resistance. Now, this basically proves why the PF is achieved with the first and second generation TKIs, namely first generation TKIs, namely gefitinib and erlotinib. You will see their PFS is roughly bound by, say, 9 to 10 months, 9 to 11 months at the max. But if you see the second generation ones, gefitinib, afatinib and dacometinib has a PFS rate of, say, 14.7 months. And afatinib in the Asian subgroup population, as seen in LuxLung 6, would probably be 13.7 months. So they are in the range of 13 to 14 months, whereas erlotinib and gefitinib has a range of 9 to 11 months. Whereas after the third generation TKIs, the tumor clones are very, very heterogeneous. And finding out a mutation is really out of the question in that condition, and we are only left around with chemotherapy. So that's basically a hypothesis behind why we should be very subtle in choosing our drug in the first line. Now, this is what the molecular mechanisms we have heard. If this has already been highlighted by Dr. Roy, but I must say, when we were students, we were asked upon a question, what was the commonest way by which you develop resistance in lung cancer, in non-small cell lung cancer? The answer was only one-liner. It was small cell lung cancer, because our gamut of knowledge was purely restricted to what we knew. It is a small cell transformation. Now, as slowly time came by, we started to understand we had developed so many things, and we started to find out with the next-gen sequencing picking up like anything, we could find out what were the real mechanisms by which the resistant mutations are actually happening. So now we have at least 60% cases, the resistance is caused by T790M mutations. And look at where the answer, the main answer in our student life 15 years ago, small cell lung cancer or small cell transformation, that is only in 2 to 3%. Pure small cell 1%, small cell with T790M 2%, small cell with MET amplification 1%. So this is our gamut of knowledge, and the unknown part is only 18%, whereas in our student lives, the unknown part was more than 90%. So this is where we have moved on. And we must understand that likelihood of acquiring a T790M mutation is 1.5 times if you compare deletion 19 versus L858R. Now, slowly our science is moving to be specific for each and every exons that the mutations are found upon. And last few nights ago, we were hearing a talk of Dr. Dhanasham Biswas, where he purely had a presentation based on the differences of the two mutations, namely DEL19 and L858R. And it is now known that it has a world of a difference with a drug only indicated for DEL19. I'll talk to you about that in my later slides. So if you're using Osimatri, what are the commonest resistant mutations found? The commonest resistant mutations found, this is also very new because you can look at the year of publication. Not long ago, it was done in 2019. They found MET amplification, the most common way, which is 15%, and that EGFR C797S mutation in 7%. Otherwise, there is also a 14% risk of histological transformation altogether. So if you say what kind of histological transformation, probably it would be a small cell transformation. So basically, if you're using osimertinib in your first line, your second line is jammed up. MET amplification, true, we now have a drug known as capmatinib against MET amplified non-small cell lung cancers. But having said that, it is really far from being used in the second line after you have used in osimertinib. We don't have data for that. Now, if you look at the osimertinib's trial, this is the FLORA trial, and this is a breakup of trial, and believe it, we are only going to talk about cross-trial comparisons, which might not look very good. But it is for the sake of science, you have to understand that in osimertinib arm of FLORA study, 47 patients actually received second line treatment. Only 50% or less than 50% received the second line, out of which 68% patients received cytotoxic chemotherapy. But having said that, if you look at the comparator arm that had used a first generation TKI, gefitinib against osimertinib, only 22% of the patients in the second line were treated with chemotherapy. So this gives us an idea, if you're using a TKI or a first and second generation TKI in the first line, you basically have a broader chance of having a non-chemotherapy based treatment in a second line. So this is the flow known to most of us. Most of our students already know this. If you're using a first and second generation TKI and the disease progresses, we now go in for a T790M mutation. If we have found that mutation, we will use the osimertinib, and after that, we are left with nothing but chemo. But if you do not find a T790M mutation after your first and second generation TKI, then you're left around with chemotherapy. And after the TKI rechallenge hardly produces anything. And we know that EGFR mutation patients, they're not good patients to be doing good, or they're not predicted to be doing good on immunotherapy. But if you're using osimertinib upfront, we don't have anything in between. You directly have to go in for chemo. So let's look at this study. It's a real world study, GeoTag, which is a very, very interesting study. Hochmeyer actually went forward with this publication in Future Oncology in 2018 and came up with the updates once again in 2020. It's a real world data, but let's look at this study in very, very details. It's a global observational study done across 10 countries. The aim was to assess total treatment duration of sequential afatinib in patients with EGFR mutated non-small cell lung cancers with T790M acquired resistance in the real world practice. So it was a continuum study or a sequencing study where patients upfront were treated with afatinib, followed by, in the EGFR mutated group, they were treated with osimertinib. So eligible patients, common mutations DEL19, L858R, TKI naive, advanced non-small cell lung cancer, age more than 18, ECOG PS 0 to 3. Once again, I repeat, ECOG PS 0 to 3. This helps us to understand how a real world trial will be differing from the strict randomized control trials that would never allow a ECOG PS 3 patient to be accepted within the data analysis. Initially treated with first-line treatment, upon progression, patients who had developed T790M mutations would receive second-line osimertinib. The primary objectives were, of course, to find out or determine the time on treatment of afatinib as first-line, followed by osimertinib. The secondary objectives were to determine the updated time on treatment in the various subgroups and to determine the overall survival of the various subgroups. So this is your flow chart. Stage 3B and 4 non-small cell lung cancer, DEL19, L858R mutated, EGFR mutated patients receiving afatinib in the first line. Then those who were found to have T790M mutations were receiving osimertinib, and data was analyzed exactly 10 months after osimertinib initiation. So patients must have initiated osimertinib 10 months prior to data collection, and they say that there was no cutoff on the minimum duration of afatinib use. And there was, of course, no lower limit on the duration of osimertinib treatment as well. So that is more towards what happens in real life. These are the measures that were used to reduce bias. You can see all consecutive patients were taken who were fulfilling the inclusion criteria. They had allowed only 15 patients per site, and it was a study done over 10 countries. Now, patients with a baseline brain metastasis and ECOG PS more than 2 were also included. This is very close to the real life, because if you see, I had talked about the second generation drug dacometinib, the Archer study 1050 that had used dacometinib and brought forward the Pfizer's drug, which is doing good in very in major circumstances. They actually excluded any patients with brain mets because it had a mandatory scans of the brain. Any patients having anything in the brain were left out. So the real world setting doesn't happen like that. And this is a very close study that can replicate the real world setting. And moreover, there was no cutoff on the minimum duration of afatinib or the use of osimertinib. So as I said, real world evidence cannot be matched with a clinical trial, but real world evidence sometimes include patients who often get excluded in a clinical trial. Having said that, the age more than 65, we had 35% patients in this geotag. There was no restrictions on the initial dose of the patients because 1/6 of the patients initiated afatinib less than 40. We all understand, we have all understood over this period of 7, 8 years or 10 years of experience on afatinib that sometimes we bring down our doses of 40 milligram of afatinib to 30 milligram. We have learned to tackle the diarrhea and the skin rashes. So even 30 milligram was included. So it also included patients more than ECOG PS2, and ECOG PS2 and 3 patients were more than 15%. So we had not left around, or geotag did not leave around lower compliant patients. They allowed polypharmacy. And if anybody who has been through clinical trials, you will understand there is a very interesting term known as CONMED. What is CONMED? It is concomitant medications. All the PIs have the chart of concomitant medicines basically pasted on their almirahs because you have a list of at least 30 drugs or a 40 drugs list of CONMEDs which you can't use with the as a principal investigator with your investigative drug. But they had no issues in geotag with the CONMEDs. And they had also included loss to follow-up patients. So this is really close to the real world. Now, let's look at the results. The results, time on treatment with afatinib, 11.9 months. And this is exactly what you find in the LUX-Lung 3 or the LUX-Lung 6 or the LUX-Lung 7. 3 was PEMSIS as compared to afatinib. LUX-Lung 6 was GemSys as compared to afatinib. LUX-Lung 7 was a comparison of upfront in the first line gefitinib with afatinib. The geotag study shows that their PFS is exactly in range of what the LUX-Lung studies had shown. So the real world is basically matching the clinical trials. So let's look at the time on treatment for the sequence. Time on treatment, overall time on treatment. You can find the time on treatment overall population is 27 months for this combination or for the sequence. Time on treatment in the DEL19 patients, more than 30 months. Time on treatment for the Asian patients, more than 37 months. Time on treatment for the older patient groups was around, say, for the more than 65 years patients, they had 38 months, 27.3 months, pardon me. Now let's look at the time on treatment for patients who had brain mets. Definitely, they did worse than the patients who were not having brain mets, but still they did 22.2 months as compared to 28.1 months. So even the brain mets patients had substantial limit of time on treatment. Now let's look at the overall survival. Median overall survival, more than 37.6 months. So that is more than 3 years. So the survival probability at 2 years is more than 80%. Let's look at the overall survival in the ECOG PS. If you look at the ECOG PS 0 to 1, they had a median overall survival of 41 months as compared to 32 months for ECOG PS2. So it also goes to show that response to sequencing in ECOG PS more than equal to 2 also had pronounced outcomes. Let's look at the DEL19 patients. Overall survival with this sequence is 41.6 months. So 2 years probability of roughly around 85%. So this sequence is showing excellent results. If you look at the Asian population as well, the overall survival with the sequence of afatinib followed by osimertinib is in the range of 44.8 months. So this is your overall results. The time on treatment, overall 27 months, L858 and 19 months, brain mets 22.2 months, ECOG PS more than 22.2 months. Now let's look at the better side. Those without Bren-Mets, 28.1 months. Del-19, 30 months. ECOG PS 0 to 1, 30 months. Asian patients, 37 months. Asians with Del-19, 40 months time on treatment. Overall survival almost has a similar picture. The overall survival is 37.6 months, and I would like you to remember this value, 37.6 months, because I am going to show you a comparison with the other drugs, which is nearly the same if you use some other sequence. Now, having said that, even the overall survival is reflected by what we saw in the time on treatment slide in the previous one. So having said that, let's now delve into other data that would help us to understand what to use the best in the first line. So this is a publication that had shown a first-gen TKI followed by osimertinib, or second-generation TKI afatinib followed by osimertinib. And this is a retrospective multi-center single country study which compares the responses of osimertinib in the two groups. That is, two divided groups. One had first-gen TKI followed by osimertinib. The next one had afatinib followed by osimertinib. If you look at the right-hand side, you will find everything favors the upfront use of afatinib, and the differences are huge. The response rate and the disease control rate, they are substantially and clinically significantly different if you're using afatinib as compared to gefitinib or erlotinib in the first generation. That is in the first line before using your osimertinib. And this is your PFS with osimertinib. You can find if you have used upfront afatinib, the PFS is 17 months as compared to roughly 10 months if you have used a gefitinib or an erlotinib. Now, this is another study. It's a population-based single-center retrospective review of patients with EGFR mutated non-small cell lung cancer who were initially treated with first or second-generation TKI. Now, let's look at the outcome. If you had used afatinib as compared to gefitinib and erlotinib, everything, the entire cohort or exon deletion or your uncommon mutations or L858R, everything favors the use of afatinib in the first line in comparison to your gefitinib and erlotinib. But it must be remembered, it's a population-based study done in a single country in multiple centers. Two other publications, one by Gerard et al., observational study from French nationwide claims and hospitalization database. They also found a time on treatment of 34 months with an overall survival of 37 months, roughly similar to the finding from Japan. OS in patients who received osimertinib following afatinib was 49.6 months. So this is substantially equal to what the geotech study had shown. So with this, I would come to a cartoon on sequencing that shares, if you look at the lower part of the study, which is the FLORA data of osimertinib, you will find that they included patients of ECOG PS 0 to 1. They had given osimertinib, and you can find a flamboyant first-line PFS of 18.9 months. But what next? You only had chemo or best supportive care, and overall they came down to 38.6 months. I asked you to remember 37.6 months overall survival in the geotech population where they had given upfront afatinib followed by osimertinib. Now, if you have used the geotech data, you will find afatinib followed by osimertinib, then they were used chemotherapy, and then they were given chemo plus best supportive care, and they came down to 37.6 months. This is the overall population of geotech. Now, if you compare the better part of the geotech study that had patients included in the ECOG PS 0 to 1 having no Bren-Mets, now let's see what the data looks like. So in the better part of geotech group, if you only look at the ECOG PS 0 to 1 patients, you will find the use of afatinib followed by osimertinib already gives you a 30-month benefit, and after that you use chemo and best supportive care, and you end up crossing 40 months. So now it's up to all of us to decide which sequencing to go around, because there are so many factors that is going to help us. Except for this cartoon, there are so many other factors that are going to help us to decide on which first-line treatment to be selected before we move on or think about the second-line things. So putting overall survival in context, first-generation TKIs, that is gefitinib, at the end of the day, you end up having 22 to 28 months, erlotinib, roughly 32 months, afatinib, 32 to 38 months, dacomitinib, 34 to 37 months, osimertinib, 39 months, and the combination of afatinib followed by osimertinib, combination of the sequence of using afatinib followed by osimertinib is the highest, 37 to 46 months, but this is specific for the TEAM790M mutated group, that is the acquired resistance group. The combinations with chemo or BEV or RAMI is also showing excellent results. We have this Japanese data showing 52 months with the combination of gefitinib and chemotherapy. And we also have a publication from Tata Memorial Hospital that had shown PEM carbo with GEF showing excellent results if you compare with only PEM carbo in the EGFR mutated group. So having said that, this is your overall survival context. And I would have seriously liked to thank you, but this is a scientific forum. And we have to show the other side of the story as well, because the story doesn't end here. There are so many things we need to decide. Now, in most of the studies, 1/3 of the patients do not actually survive to receive the second-line treatment. You have to understand that. In your clinical practice, how many patients survive to go on to receive second-line treatment? You have to ask that to yourself in front of a mirror to take a call on which first line to go ahead with. Now, this is a fantastic cartoon. You see, out of your 100 patients, roughly around 73 to 77% patients will be fit for a second line. Out of them, if they're EGFR mutated and you have used the first generation or the second generation TKI, you will lose 25% patients who will not be fit for the second line. And out of them, you will go in 60 to 76% patients will go in for a valid test for T790M, and out of which 50% is going to be positive. So basically, you end up only 30% patients who will be eligible to be receiving osimertinib. So this is also a food for thought that what is to be gone ahead with. Now, the geotech study that had shown, is it sacrosanct? Is it all to be taken home from? You have to understand there are also certain nitty-gritties which we want to highlight. That it was a retrospective observation analysis. They excluded the patients that were T790M negative or that were not tested at all. They excluded the patients that died after first line afatinib. They also excluded patients that could not receive second line therapy. So you have to understand it may be a real world data, but there were still certain things that needs to be consideration. The geotech time endpoints were the primary endpoints was time on treatment. Is it progression-free survival, which is sacrosanct for us? It is not. It is not equal to progression-free survival. The OS data was exploratory. You have to understand it is not a randomized controlled trial that had given us exact overall survival. It is exploratory analysis. Therefore, it is definitely not good enough to draw any conclusion on which sequencing therapy to be used. Fine, it is an excellent study, but not a sacrosanct study. You will have to take things with a pinch of salt. This is your NCCN guidelines. Look at this and decide on your own. Your preferred regime in the first line is osimertinib, but once again, you have to understand what is NCCN. NCCN is a guideline that is framed by the participants lifting up their hands. So NCCN is also not sacrosanct. It is you and each of your patient in front of you. You have to take the call based on the evidences that you have in your hand. So your final take home should be based on efficacy, safety, quality of life, and overall survival. Having said that, I'll quickly skip through certain things. This is your entire gamut. In your entire gamut, you will understand the best PFS was achieved with osimertinib. But you will have to understand it is very, very costly drug, and you don't have anything after that. You have to understand the best PFS achieved with ELIT5-8R or DEL19 was with osimertinib. If you compare it with dacomitinib or afatinib, you have to understand the maximum duration of response or overall response rate was osimertinib 80%, dacomitinib 75%, and your first and second generation 70%. You have to keep these things in mind. You have to understand the overall survival data of osimertinib, 38.6 months. This is what was shown in your cartoon, in spite of a 31% crossover rate. This is also very, very significant. You can't forget the dose reductions required in the Lux-Lung 7 or the Archer or the Flora. You can compare it 4%, 66%, 52%, and also your quality of lives. So having said that, you now seriously have a problem whether to go ahead using osimertinib followed by afatinib followed by osimertinib, because you now have a query in your mind that your 1/3 of the patients might not end up receiving second line at all. So are we losing the opportunity of giving the best drug up front? That's a question. Having said that, we don't have any generic osimertinib. Look at the cost and complications of osimertinib as well. If you use osimertinib up front, what do you use in your second line? So you are basically left around with severe food for thought. You are the one who's going to take the call to decide upon what is your first line choice, whether it is geotag or it is any other sequence. So with that, I would like to end my talk. And I think we now have only wrap up to be done. But before that, I think there are certain questions in the chat box. And
yes, sir.
If Dr. Amitabh Rai is with me, I suppose he's going to respond to the chat box. And Dr. Niranjan Prabhu, can you just exactly tell us what are the questions there in the chat box?
Yes, sir. Sure, sir. Sure. Sir, and indeed, that was a brilliant and wonderful presentation, sir, actually. A lot of new things even we got to learn today, I believe. And it will be same. I mean, others' opinion also will be the same on this. And it was very neutrally put. That's very, very nice, sir, actually. Thank you so much for that talk.
So, if
we have
questions.
We have 4 questions, sir. So first question is by Dr. Ipsita. So what is the opinion about LDRT to treat COVID? Already Dr. Amitabh has taken it in chat box, but sir, if you can share some more thoughts on that.
Yeah, so LDR for COVID is basically in a very defined, well-defined subgroup of COVID patients. You're using very low doses of radiation. What's being done there is essentially a lung bath, something that has been used in oncology, especially in this time, at a point in time where we did not have very effective chemotherapies for very aggressive cancers like Ewing sarcoma and so on. We did have this concept of using lung bath or low dose radiation to bilateral lungs, and was shown to be efficacious. Now with the advent of chemotherapy, we kind of forgot about it. Now with this new thing coming in, what seems to be the problem is basically an immune response which is leading to the lung damage rather than the infection itself. So radiation used in low doses has been used as an immunosuppressant, especially in bone marrow transplant recipients for reduction of immunity as well as creating space in the bone marrow and so on. So this is one area which is established as a treatment paradigm in oncology and is being kind of borrowed by colleagues to give some respite. But having said that, we are not in with a lot of data regarding this, specifically the long-term data, long-term safety of the use of low-dose radiation in patients with COVID. There are many ongoing trials, some of which with interim results have shown reduction in oxygen requirement and better outcomes as compared to non-radiated patients. We don't have any randomized prospective data to be able to make these informed decisions about. We're happy to say that even India has a couple of 3 or 4 centers which have been registered for trials, and also equipment which has been designed to deliver LDR, low-dose radiotherapy to the bilateral lungs, specifically designed in India and now being used in India. So this is an area of active investigation. It is showing benefit, and I think the decision needs to be made on case-to-case basis. And as far as infrastructural and logistical requirements go, most of our hospitals which are actually dealing with COVID are not equipped to provide this kind of treatment. So the onus is upon us radiation oncologists to offer this service and to be proactive in coming forward and offering this to our critical care and pulmonology colleagues as being something they could possibly think about as an option in treating their patients with COVID. So all in all, I know it's not a direct answer, but it's the best information we have with us right now.
Right. Thank you so much, sir, for that. Now, the next question is by Dr. Yasiru Malinda. Is rebiopsy and mutation analysis for T790M mandatory before changing it from afatinib to osimertinib? So basically, he is asking whether, yes, sir. Yes, sir.
In the geotech study, it mandated because they left around the patients who were not mutated were not included in the geotech study. So if you have to believe geotech, then you will have to go ahead with T790M mutation.
Go ahead with the mutation.
Either from the blood, and if you don't get it from the blood, then you will have to go in for a rebiopsy, or from the tissue, we'll have to find out.
Right. Right. Sir, actually, in the same context to this question, I would like to bring to your notice that recently there was one publication which I had gone through. It was a single center study, but where the patients, when they underwent the rebiopsy for the first time, so the T790M incidence was only around 36%. But when the same patients were subjected to multiple other rebiopsies for different reasons, like from the different sites or from the same tissue from a different site, or from a different, entirely from a different sample itself, like from metastasis or from blood, like liquid biopsy or something. The incidence of T790M in the same patients went up to 80%, right from 36% to 80%, the same T790M mutation. So what is your opinion on that? Is it practical, or is it possible in India, like doing multiple repeated rebiopsy, or should we go ahead with osimatri, like a person asked in the, like one of the doctor asked in the chat, without doing the T790M?
I think this study is it should be taken anecdotally because it doesn't look very feasible in our context in India. We can't subject to a single rebiopsy, forget multiple rebiopsies from various reasons. I suppose even my colleague Dr. Amitabh is going to second this idea.
So I think Dr. Niranjan has, kind of, scratched the surface of something that we have all been fighting for a very long time. Lung is not something that you can access very easily. It requires a lot of courage for even the best interventional radiologists to do rebiopsies on most patients. Now, the fact that we have these options available to us makes us more comfortable asking for rebiopsies as compared to the past. But having said that, the question that I think has been raised in the past is where to do the rebiopsy from if you are actually asking for a rebiopsy. So essentially, the question that you actually were trying to explore when you were looking at the literature. So what I believe Dr. Chatterjee and I, both of us, tend to follow is we tend to guide our interventional radiologists as to, if at all they want to take a sample, take it from a sample which is either, which is either a new lesion on radiology, preferably on a PET CT, you have a new lesion come up which has a high SUV value, or if you do not have a new lesion, you have progression at the primary site, try to put in your needle at the site which shows the highest SUV uptake. That would essentially reflect the heterogeneity of the cancer, and specifically in these driver-driven, cancers that we are now getting to see across the board for so many subsites. We know of this heterogeneity in response happening all across. In fact, we now even have a term for this. We have a term called oligoprogression versus global progression for mutation positive driver-driven cancers with on treatment with targeted agents. So for the oligoprogression definition, you need to have a whole body scan confirming progression at certain sites, going by which guideline you're following. It could be organ-based, site-based, number-based, but there is now a subgroup where treatment paradigms are also different. So it is not just a question of, where to take the biopsy from. It's also a question of how many new sites you're now looking at. And typically you would not get very encouraging results if you were trying to put in a needle without actually investigating for all subsites, the possibly biological uptakes. And with that in mind, it might seem to be better off doing liquid biopsies, especially in this group of patients. But having said that, the specificity or the sensitivity of liquid biopsy seems to be slightly lower as compared to, taking tissue biopsies in the context of lung cancer. So that's a question I think we will need some time for us to, come up with very correct answers for. But I think the rule of thumb that all of us try to follow is try to guide our interventional radiologists to a site which we think would be able to answer a question that is being raised here, like in this context with, small cell transformation versus T790M, like Dr. Chatterjee pointed out a little while back. It's not a one answer fits all question kind of a situation anymore. You could have so many reasons for progression that you might be diagnosed.
And with the heterogeneity of the tumor, definitely we can't be very sure. Even from the same tumor from different sites, we might be able to pick up certain mutation and miss certain mutations due to those spatiotemporal heterogeneity in the tumors. Absolutely, sir. And recently, one more publication where I saw where pulmonary versus extrapulmonary is what they compared. And in the pulmonary sites, they found more T790M compared to extrapulmonary sites. So that was one more point to speculate, actually. Absolutely, I agree, sir. There are no further questions, actually. So, sir, if you're okay, we can conclude, sir. I think we have even overshot the time. I mean, the meeting was absolutely fantastic, but I mean, the time, I mean, it's okay. But I mean, the audience also will share the same thought that time, we didn't really feel that the time actually flew. It was a brilliant discussion. Thank you. Thank you so much, sir.
Thank you very much.
Can we conclude, sir?
Yeah, thank you, all of you. Yeah.
Thank you so much, sir. Like on behalf of BHI, I would like to thank all our speakers and our participants. I mean, it was a brilliant discussion once again. Very, very lot of food for thought and a lot of points that was actually under debate today. And I believe it would be same for all the other participants. And I will also extend my thanks to Kavina Creations for providing the technical support. And thanks once again for our beloved speakers, Dr. Amitabh
Dr.
sir and
Parikh sir
Koushik
was
sir.
there. Yeah.
Yes.
Yes.
Thank you, Dr. Purvi sir. Thank you so much, sir.
Sir, please stay safe, all of you, and thank you so much.
Sir is on mute actually. Thank you so much, sir.